At the outset, I would like to thank the organizers for giving me this opportunity. My topic is Exposure of Heart in Lung Cancer Radiation Therapy, which is a Green Journal publication this year. And it is a systematic review of heart doses published between 2013 and 2020. So we all know that radiotherapy is used to treat NSCLC, early stage NSCLC not suitable for surgery, and limited stage small cell. Incidental exposure of heart, of course, is unavoidable in most of the patient, and there is data and there is evidence that it increases the risk of cardiac disease, including IHD, heart failure, valvular heart disease, pericardial disease, conductive system abnormalities. Traditionally, in lung cancer, we were more worried about acute toxicities earlier, but however, now due to early detection, tobacco control intervention, and improved treatment, late toxicities have also come into play. The RTOG 0617 reported an association between heart dose parameters such as V5 and poor overall survival. Similarly, in another study, a patient with pre-existing cardiac disease, the mean heart doses of 5 and 12 gray predicted grade 3 cardiac event rates of 10 to 15%. So the aim of this study is to present a systematic review of heart doses reported in the modern era of lung cancer radiotherapy. The heart doses variation were documented according to the region irradiated, laterality, treatment modality, and planning technique. And the aim of the study is also to summarize treatment strategies such as motion management or use of particle therapies, which may help in reduction of the heart dose. So initially they had evaluated almost 8,500 publications, and finally they selected 2,281 publications, of which 243 had some measure of heart dose only, 32 studies measured doses to cardiac substructures, and 6 studies 32 studies measured doses to cardiac substructures and the whole heart mean dose, and 6 studies talked only about doses to cardiac substructures. So data extraction, the following were included. Regimens were categorized according to treatment modality, radiation modality, treatment planning technique, and respiratory motion management. Respiratory motion management had a non-active approach like, assessing the ITV, the internal target volume, or an active approach like expiratory gating or DIBH, that is deep inspiratory breath hold technique. Whole heart doses, that is average mean heart dose, and average maximum doses were compared, as I have mentioned earlier also, according to laterality, lobar regions irradiated, treatment modality, radiation modality, treatment planning technique, and use of respiratory motion management techniques. So results, let's come to the results. So they have listed in terms of studies which had SABR versus studies which had non-SABR. And this is the first plot which is listing based on the technique used, that is 3D CRT, IMRT, particle therapy, that is proton or carbon ion. Two significant findings in this list is particle therapy improved the cardiac doses, that is patients who underwent particle therapy had less cardiac doses. Contrary to RTOG 0617, the cardiac doses in 3D CRT versus IMRT were not different in this meta-analysis, whereas in RTOG 0617, the IMRT doses were better. Similarly, so this is what I have been talking about. In terms of location, for SABR, the mean heart dose was higher for right-sided patient as compared to the mean heart doses in patients who had left-sided disease. For non-SABR technique, the exposure to the right side and left side did not really matter. This is what the table signifies, what I have just said. Similarly, talking about the mean heart dose stage-wise, in SABR techniques, of course, they have not managed to address it stage-wise because SABR would have been for early stage disease. However, for non-SABR technique, the heart dose have been lesser in early stages as compared to heart dose, which are more in late stages. Hard dose varying according to the radiation modality and treatment planning techniques. As I have said, mean hard dose were lower for particle beam therapy. IMRT and 3D CRT did not have much significant difference in SABR technique. Even in non-SABR technique, IMRT and 3D CRT did not have much difference in terms of hard dose, which was contrary to the large randomized controlled trials and especially 0617. This is by the beam planning, the beam arrangement, that is static entry IMRT, volumetric modulated arc, helical tomotherapy, robotic-driven system, and particle therapy, carbon ion. Particle therapy and robotic-driven system fared better in terms of hard doses. However, the number of patients were very less very less in the patients who underwent robotic-driven radiation therapy. Hard doses varying according to respiratory motion management. Of course, the patient who had used active respiratory motion management, they fared better for SABR as well as the non-SABR arm. Active radiation patients who had active motion management, their cardiac doses were 2.4 as compared to 5 gray in patients who did not have an active motion management. So this is to denote the same. And which motion management system fared the best? Mid-ventilation system in the SABR arm or deep inspiratory breath hold techniques. These are the two systems which fared the best. So discussion, as yet there are no international guidelines on dose reporting for the heart or substructures of the heart with respect to the lung cancer radiation. Hard doses were much lesser in SABR. Hard doses were much lesser in SABR technique than in non-SABR technique. That's understandable because SABR was used for early stage tumors and the volumes would have been smaller. Despite wise use of inverse planning, the results showed the hard doses are similar in 3D CRT and IMRT regime. So to sum it up, I think we are short of time. To sum it up, the benefits of this study was, this is one meta-analysis which has talked about hard dose in lung cancer, which no other meta-analysis has talked before. The minus points or the negatives of the study are, this study did not include the volume of individual patient series. The volume of the tumor treated were not included. And the second criticism was the data was very heterogeneous and it had comprised of a lot of data, a lot of study. Thank you.